everyone. Today we will be talking about post-traumatic stress disorder, also known as PTSD in children and adolescents. PTSD is an acute emotional response to a traumatic event associated with severe environmental stressors. Individuals often experience intense fear and helplessness towards specific triggering events. Effects of PTSD depend on the severity of the traumatic event, physical proximity, and parental reaction to the traumatic event. It is important to recognize that children and adolescents may have trouble forming interpersonal, social, or occupational relationships and can find it difficult to build trust due to their trauma. Signs and symptoms of PTSD typically occur within 3 months of trauma, but delay for up to a year is common. Very young children experience more physical symptoms such as sleep disturbances. This age group may also lose acquired developmental skills such as toilet training. Elementary school-aged children often exhibit time skew symptoms, which is when a child missequences trauma-related events when recalling the memory. They also exhibit a symptom called omen formation, where the child believes that there were warning signs that predicted the traumatic event. It is also common for this age group to participate in post-traumatic play or impersonate trauma through drawings or verbalizations. Adolescents and teens often reenact traumatic events, which are incorporated into their daily lives. This age group is also more likely to exhibit impulsive and aggressive behaviors. Children and adolescents may also experience severe anxiety, self-blame, panic, and maladaptive appraisals.
The next topic is assessment. Nurses play an essential role in assessing children and adolescents for PTSD, so it's important to be non-judgmental. Nurses should assess for signs and symptoms of intrusion, avoidance, negative alterations in mood and cognition, and hyperarousal. Nurses should also assess how trauma has impacted the client's ability to function in different domains, such as interpersonal relationships and family function. Nurses can help prevent re-traumatization by identifying signs of PTSD early on. There are many tools that can be used to assess for PTSD in children and adolescents, such as the Child and Adolescent Trauma Screen, or the CATS, and the Clinically Administered PTSD Scale for Children and Adolescents, or the CAPS-CA. Next, I'll be explaining the goals of PTSD treatment. One of the goals of PTSD treatment is to reduce the emotional and physical symptoms, such as nightmares and difficulty sleeping. The next goal is to improve daily functioning, such as eating habits. The final goal is to help the person cope with the event that triggered their PTSD. Strategies for coping may include speaking to a loved one or a professional.
The next topic is nursing interventions. Usually, nurses are the first healthcare providers that identify PTSD in patients and care for them. Here are some interventions that nurses can implement when caring for patients with PTSD. First off, nurses should educate patients on what PTSD is and its associated causes and symptoms. When working with patients and their support systems, it is important to establish trusting, comforting, and non-judgmental relationships. Nurses should give patients time and opportunities to express their feelings and make sure that they feel safe and heard. Nurses must provide patients with positive coping strategies during their treatment, making sure to remind them that setbacks in the healing process are completely normal. It is also important for nurses to educate patients on healthy lifestyle activities that they can incorporate into their daily lives. For example, some of these methods can include doing yoga or meditation. Lastly, nurses should refer patients with PTSD to other sources of support, such as local support groups.
Our final topic that we will be discussing is future research recommendations. As we're still in the beginnings of our research on PTSD in children and adolescents, it's recommended to have better quality studies that are longitudinal. This means looking at the same individuals over long periods of time rather than looking at a bigger group of individuals over shorter periods. It's also important to have altered psychotherapies so that we can achieve the needs of young children. It could also be relevant to research and understand the possibility of early pharmacotherapy if it is needed for that specific individual or their situation. We could also use a more dimensional approach to therapy over a categorical approach. This would mean that we'd be using a more hybrid classification and would be more quantitative than qualitative. While also looking at the individual, we should look at the family as well, things that go beyond direct associations, and look at the resiliency of the individuals affected. More attention to be given to post-treatment residual symptoms like insomnia and detachment and vulnerability to new traumatic events. Systematic research of understanding the underlying mechanisms of action can also help to figure out the most effective ways to treat certain clients and developing treatments that are more specific to each individual rather than treating everyone as a group.